The trickiest part with implanting the Parr Optogenetic Telemeter relates to the duration of the surgery, I guess. And so it's really critical when you're doing a long surgery to keep everything clean. And this is especially the case if you're implanting something in an animal that's going to be in that animal for months. For the surgical procedure, what we do is we position the body of the telemeter in the abdomen of the rat, and then we feed the cables up to the head. So the cables are the fibre optic cable and the biopotential leads. We make a subcutaneous tunnel from the abdomen up to the neck, feed the cables up with a trocar, and then we position the animal in a stereotaxic frame, prepare the skull for stereotaxic surgery, and then firstly position the biopotential channels. We're recording EEG over the motor cortex, so we make small holes above the motor cortex where we position a screw to attach the positive biopotential lead, and then another screw over the cerebellum to attach the negative biopotential lead. When we first started to use the Parr telemeters, we had to change a number of different things in our standard surgical protocol to adjust for this device. When we first started using the Parr telemetry system, we were using ketamine domitor injectable anaesthetic mix, which is really good for short surgeries. It's not so good for long surgeries. A major improvement we found was switching to isoflurane, a gaseous anaesthetic, which allowed us to keep the animals on a consistent plane of anaesthesia for a long period of time, and also not over-anaesthetize the animals so that when we finish the surgery, they can quickly recover. The second thing that we had to change when we started to use the Parr telemeter is how we close the surgical wound. So in the past, we'd used surgical clips. They're really good when the animal can't get to those clips, but when they're on the abdomen, the animal can access those clips and remove them after the surgery, which can then lead to infection. So one thing we had to change that took some time getting used to is we had to learn how to do intradermal sutures. This is a suture that you do through the skin and you can bury it under the skin, so the animal can't access the suture material and therefore can't break open the abdominal wound. I would absolutely recommend anyone thinking of using the Parr Optogenetic Telemetry system to have a base level of experience with stereotaxic surgery. The level of error that you get with stereotaxic surgery is ultimately a function of how much experience the researcher has with stereotaxic surgery, particularly with that brain region. And also a major factor that we've found is the size of the animals. So the heavier the animals they get, the easier it is to do the implant surgery, but also the more inaccurate the stereotaxic surgery becomes. It is possible that you can use animals over 350 grams. We have been using animals at 500 grams. And that's mainly because we do two surgeries. So we do a surgery to induce the Parkinsonian lesion and then a surgery to implant the device, and by then they're much heavier. We've also had COVID to deal with, which means that the time in between the two surgeries has been much longer than we had hoped. So it's possible, you just have to expect a certain level of error as a result of having heavier animals. The reason for error in stereotaxic surgery in heavier animals is mostly because the references on the skull surface change in relation to the areas of the brain. So as the animal grows, the head gets bigger, and so the skull grows, but the brain doesn't necessarily grow as much. These are the biopotential leads here that in my research I'm using to measure EEG activity over the motor cortex. And then this cable here is the fibre optic cable. At the end of the fibre optic cable, there's a cannula that we've had affixed to it. We use this cannula to grab onto the fibre optic during stereotactic surgery so that we can insert it into the brain. We insert it just beneath where the thick bit here is. When we insert this into the brain, we have to then build a dental cement cap around the fibre optic. So what we have to do is we have to bend the fibre optic
And a critical thing is knowing how much you can bend it without it snapping.
I think someone coming in with a background in stereotaxic surgery, at a minimum, it would only take a handful of surgeries to become proficient with implanting the Parr-Brownlie telemetry device.